Today I'm speaking with Dr. Rick Bosshardt and Dr. Celia Nelson. And I've spoken with you, Rick, a couple of times in the past. We had a conversation about your concerns around DEI in surgery. And we also had a conversation coming from your perspective as a plastic surgeon around some of the gender care that's being done. So I'll link to both of those conversations in the notes underneath of this message or this video here. And Celia, this is our first time meeting, and I understand that you also have some concerns around how DEI is impacting medicine and surgery, and I look forward to hearing from you. Would you mind maybe starting by saying a little bit about your background?
Sure. I'm a general surgeon. Rick is a plastic surgeon, but I've been in practice like Rick for about 30 years. I finished my training in 1992, and I've been in practice right here in Central Florida since then. So this is my 32nd year of practice. And for surgeons, the soonest you can become eligible to be a fellow of the American College of Surgeons is about 3 years or so after you've started practice. So I've been a fellow of the American College of Surgeons as soon as I became eligible, which was about 1995. So I've been a fellow since then, and I've been practicing as a general surgeon here in Central Florida in the Lake County area north of Orlando, where Rick also practices as a general surgeon, and we work together. We share patients. So I came here from Virginia, which is where I did my training. I went to undergrad, medical school, and my surgical residency training all in Richmond, Virginia, at VCU and Medical College of Virginia, it was called then. Now it's called the School of Medicine of Virginia Commonwealth University. So I finished my training there in 92 and came to Florida. I'm originally from Jamaica, which is where I was born. And we left Jamaica when I was 17 in 1979. And I've been living here since then and became a US citizen while I was in medical school. So sometime in the early 80s, I don't remember the exact date, but sometime in the early 80s, everything in medical school is a kind of a blur. But I've been a naturalized American citizen since. I know, right? As a matter of fact, this whole 30 years has been a blur. I can't believe 30 years has gone by. I've been a surgeon 30 years. So I've been fortunate enough to, enjoy being a surgeon. It's a joy and a privilege, really, to practice as a general surgeon all these years. It's very rewarding and very fulfilling. Very challenging, of course, and everything isn't wonderful, especially more and more regulators, more and more rules. They put you on a shorter and shorter leash. But I have to say that it's really been a joy and a privilege. So as I mentioned, Rick and I have worked together for decades, and I'm not really, even though I'm a fellow of the college, I'm not really active on the online forums and the communities, they call them, that they have. I pretty much go to the annual conference that they have probably every couple of years. I haven't been to one since COVID, actually. But for some reason, I looked at the online forum one day. I think this was about 3 years ago now, Rick, right? Was it 21?
Yes, that would have been 21.
Yes, and there's this whole conversation going on with Rick and a bunch of the other participants about this issue of race in surgery and the surgical practice of surgery being racist, and Rick was racist. It's like, what is going on? This is crazy. So I called Rick And I said, listen, I just came across these posts and I just want you to know I agree with you. I think this is ridiculous trying to say that the practice of surgery is racist, and we need to have some kind of racial consciousness in order to provide good care and to be good doctors and good people. And so I called Rick and told him that wholeheartedly supported what he was saying. And Rick shared that on the forum, because obviously, a Black female, you're not supposed to have those opinions, I guess. So the comments on the forum responding to Rick saying that they sort of acted like I was imaginary, like he had this imaginary friend who was a Black female surgeon that agreed with them. So then I posted on the forum and said, no, I'm not imaginary, I'm real. And I think this is crazy and wrongheaded, and it's poorly designed. I don't know what the goal is. So anyway, that started the back and forth, and the point I was trying to make is not that racism doesn't exist, but that, I mean, I'm a perfect example of the fact that racism doesn't exist. How else do you explain someone like me being a surgeon if this was a totally racist environment where, only so-called privileged people could succeed? It's just wrong. It's just wrong. But there was and still is an enormous amount of pushback against that thought that it is not possible that we're not all racist. There literally is that feeling that it is not possible that we're not all racist. It's just not possible. And if you can't see it, if I can't see it, it means you have internalized whiteness, I think they call it, internalized whiteness, or you're just crazy. You just can't see. You're blind. You're crazy, and you're not to be taken seriously. So it got to be too frustrating, and I don't even post on the forums anymore. I don't even read them, because at some point I have to figure out what I can do that's going to be effective as far as changing hearts or minds, or letting my voice be heard. And people are, at least on the Florida or the American College of Surgeons forum, people are entrenched. I don't see anyone open to reason or open to being persuaded that they could be wrong, or that there's a different philosophy that's worthy of being considered. There's just no room there. Wouldn't you agree, Rick? I don't think there's anybody that's persuadable there.
I think the people that have kind of run the whole enterprise of DEI and anti-racism in the ACS are exactly as you said. I think they're so sold out, entrenched. They have such a commitment to it that they can't see themselves stepping back and saying, maybe we should rethink this, and maybe we should look at this from a different angle, and perhaps we can approach things differently. I think the continual push, the DEI toolkit that came out at the end of the year that they have continually pushed on the ACS website is a perfect example. And not to belabor the issue, because I think I've said this enough, I think that the ACS canceling surgeons that disagree with them, surgeons that have the same opinion that you have, I believe are in the majority of the ACS.
Agree. Yes.
But, they're not, a lot of them aren't speaking up. Many of them are older, like me, and just don't want to engage in these battles. A number of them, I think, are just too busy with their practices to really get involved. And so you just have a very few voices out there that are trying to put this out, that maybe there's, a problem here. with the way the ACS has approached this whole issue of race within whatever race problem exists within surgery. They really have never provided an example of racism in the ACS beyond the fact that there are disparities, that we don't have as many minority surgeons as there are minorities in the society. We don't have 13% Black surgeons. We don't have 12% Hispanic, and we don't have whatever other non-binary. You name any minority category, and they're not represented in the ACS in the same degree that they are in the community. So that is de facto an example of discrimination. And I think that when you think that way, you don't find the right answers. You don't get answers. You keep going off, in the wrong direction. And I don't want to take this away from you. I want to keep, because what you're saying, Celia, is very interesting. But yes, I think you're perfectly right that the people that are doing this are absolutely, they're digging their heels in, they are doubling down. And even though DEA is in retreat in many areas of our society, I don't think DEI is in retreat yet in surgery.
If you had to, if you had to sort of give their argument, what's the DEI argument? Why do they think we need to focus on race? Do you have a strong conceptualization of that?
I think their objectives, some of which I think are good. They want to see more minorities, more women in the practice of surgery. And I think that's good. That's fine. And they want to see better health outcomes for minorities. So I think those are good goals. And I think every surgeon, every physician, every member of society wants those things, want people to succeed achieve their highest goals and dreams and aspirations, even if it includes being a general surgeon, and want folks to have good healthcare outcomes, long, healthy, happy lives. And I think that that's their goal, or their stated goal. And they have decided that the way to get there is to basically have these quotas where you have, certain, as Rick was saying, certain percentage of women, certain percentage of Blacks, certain percentage of immigrants. And they have some of this bad science saying that, patients do better if their surgeons are the same skin color. They have some very flawed data that they think supports the argument that if you have someone who looks like you, you'll have a better health outcome, which is so outrageous and so backwards. I mean, it defies even a logical response. And I know Rick mentioned to you at your last conversation about the college inviting Ibram Kendi to speak at the leadership retreat. And so we weren't allowed to be present, but they did publish the video for us to view. And it was very interesting listening to him, because he shared an experience he had as a patient. He shared that he had to have surgery for colon cancer as a patient, and went over, how he came to choose his surgeon, and ultimately said he chose a white surgeon. And I think he was saying that to tell us, see, I don't hate white people. See, I like white people. I chose a white surgeon. And he specifically mentioned that he was choosing between one surgeon who was Black, one surgeon who was white. He chose the one that was white because he thought he was more prepared, answered his questions, and knew his history. He felt more comfortable. And this is the hypocrisy. No one else is allowed to make a decision based on merit. Mm-hmm. He is telling us we have to choose the Black surgeon if we're Black. But he is allowed to make a decision based on what he thought was best for him, the person he had the best rapport with, the person he had the most confidence in. He's allowed to make a decision using those criteria, but everybody else has to choose based on color. And I don't think he even realized that's what he was saying, because he was trying to say, see, I don't hate white people, I chose a white surgeon. But what he's actually saying is, I will choose based on merit. All the rest of you need to choose based on your skin color. And that's the hypocrisy of this thing. And that's why you can't use things like, if someone wants to choose a surgeon based on their skin color, okay, fine, but don't mandate that. If that's something that's important to them and they have a choice and that's something they choose, well, fine, that's okay. But I don't think that we can say you're not going to get good care unless you have a surgeon that's the same skin color or the same sex. I mean, that's outrageous and demeaning. And the people that are pushing this aren't even following the rules they want the rest of us to live by, you know. And I mean, I've always recognized the fact that that there weren't a lot of surgeons that were Black and female, especially over the last 30 years. And I was always very self-conscious, especially seeing patients in the ER. Because you see someone in the ER, neither of you have met before. You don't have any control. I don't have control. And the patient has no control. You go there because you're having a problem. You're scared. You want help. And then someone shows up, me. I don't have control. I'm on call. I'm obligated. And here are these two people meeting that have no control over who's going to show up. And I always felt self-conscious that a patient, you know, they're afraid, they're in pain, they come to the ER, a stranger shows up and says, you need surgery, and I'm doing it. And I always wondered if that patient was scared because of I didn't look like a surgeon. I always felt self-conscious about that for years and years and years. And I mean, there's nothing I could do about it except, you know, communicate, you know, answer questions. And I'm not sure if any patients ever refused to have surgery because I walked in the room. I'm not sure. In an emergency, obviously, we don't have a choice. But I'm sure there probably were some that were apprehensive. But you don't have many options. You can tell, you know, something is wrong. You need surgery, and you're scared. Everything is scary. And here's this person that says they're the surgeon, and that's scary. Everything is scary. So I always felt self-conscious about that. Still, even now, probably in some degree, I still feel self-conscious about that. But you know, we get through it, and the patient always ultimately has a choice. But I don't think we can nowadays. I think what would happen is if when someone like me shows up, that person is thinking, okay, are they here because they're competent, or are they here because they're Black? Did somebody just say, you're Black, you're going to be a surgeon? Do they really know what they're doing? I think that's the trap, is you think you're helping Black women to become surgeons, but if you lower the standards, and if they're not really capable, then you're not really helping them or the patient. And then you paint everyone with this brush. So, okay, that must be a DEI hire. So I definitely don't want a Black female surgeon, because they're probably a DEI hire. They probably, you know, held them to a lower standard and just passed them. And I don't want that surgeon. That's the risk. And then you end up with poorly trained surgeons, and you end up really now having data with poorer outcomes, all because you're trying to fix a problem that's not even there. It's really bad, and the opportunity for lots of people to get harmed. I mean, over the years, when I used to go to these annual conventions, there were very few Black females. But the last meeting I went to, which I think was in Chicago right before COVID, there were Black females all around. I mean, there were Black female surgeons. I said the increasing number just over the last 30 years, just from going to the American College of Surgeons. So the meetings. So the problem that they're trying to fix is already fixing itself. And, you know, people really have to make a choice. This is a career the training is challenging, the career is challenging. I have colleagues that I work with that are Black males that come to me and say, my daughter wants to go into surgery. Can you talk her out of it? Can you talk her out of it? So are they racist? Because they don't want their daughter to go, and there's a Black female. I mean, because they see the lifestyle, they see the challenges, they see, can you talk, can you call her? You know, can I have her call you? Please talk her out of it. I mean, they wouldn't dare, if someone dared to counsel a high school student or whatever and say, are you sure you want to do surgery? Here's what's involved. They would be accused of being racist and all of this kind of thing. It really somebody has to be committed and has to have that desire. You can't out there decide, 5 girls from this class are going to be surgeons. That's crazy. It's not good for the practice of medicine, not good for surgeons, and it's not good for patients. We should be like Ibram Kendi and decide which surgeon we want based on our own factors. This is one I can communicate with. I think he's trained better. He seemed to know more about my history. He had looked at my CT. He said the other surgeon hadn't even looked at the CT. So we should be like Ibram Kendi. And even if that choice happens to be a white male, it's my choice to make. Don't tell me I have to have a Black surgeon just because I'm Black. That's demeaning. It's demeaning, derogatory. It's awful.
You're pointing to that hypocrisy in the purveyors of this theory or this ideology, that it's inherently underestimating everybody else and saying that you are a product of your race or these certain identity factors, and therefore we're going to treat you as such. But we know we have some special information that tells us more about your mind than you know about your own mind. Yeah. And then you speaking to the DEI quotas and hiring practices that lower standards in order to improve certain particular demographics, and how that undermines your own sense of your professional reputation, because you look around and you have these, as the standards lower, you have to wonder, do people see me as a DEI hire instead of just seeing me as a competent person?
Exactly. And they don't ever admit to quotas, but they can't explain how they're going to get to this nirvana of, DEI. How do we know when we've got there? Is it a certain percentage? They'll never say. But that's the only way you can get there. If your goal is to have the composition of surgeons match the demographics of the society as a whole, the only way you're going to get there is with quotas. If you have quotas, that means you're compromising competence or standards. They'll never admit that. I couldn't get them to admit to that on the forum, and they'll say, no, it's always going to be, performance and quality, but, we still want to have these, DEI criteria as a goal. You're going to compromise one for the other. And the fact that they're not even willing to admit that, I don't think means that that's not the goal. They're going to lower the standard in order to get to that goal if they're making that now a pillar of the society. Well, something has to give.
What would you say to I can imagine someone who is steeped in critical race theory making an argument that your experience as a Black woman surgeon, and that you describe that sense of trepidation when you walk in and you think, how are they seeing me? That would be unfair. I apologize for these phrases, but unfair emotional labor on your part. They would say that this is an unfair burden that you carry that like a white male surgeon wouldn't have to carry. And so that's part of the push to be more inclusive.
So we fix that by mandating more Black females. I don't think I think you end up with more of a shadow over the Black female surgeon, not less. I mean, you fix that, over time. And, like now I've been practicing in the same community now for 30 years. So I have a reputation, and before I even get to the ER, the nurses and the staff and the ER doctor are already saying, oh, you're in good hands. So over time, you build a reputation, your results speak for themselves, and it's your outcomes that precede you before you even show up. People already know, your history, and your reputation. So, and that's what matters most is results. At the beginning, everybody should feel somewhat self-conscious. If you're starting out in a career or a project or anything, any young surgeon, young lawyer, young accountant, young pilot, I think you should have some trepidation, whether you're a Black female or not. You should, even as an old surgeon, you should still feel, challenged to make sure you get this right. Don't mess this up. Still now, when you're seeing the patients before surgery and the family and they're talking to each other and you see how important this is somebody's wife, and I'm going to go take their gallbladder out, and you think it's okay, it's a 500 millionth gallbladder, but it's like, this is his wife, and you see the attachment, and it's still important. You feel the weight of it. That should never go away. The weight of what you're doing and the importance of it. That should never go away. So you should always have that trepidation, no matter if this is Black surgeon, Black patient, white patient, age. This is insane. It is insane. It's so destructive, so harmful. It's so obvious that it's wrong. That's the thing. It's so obvious that it's wrong. Why are they even pretending that this makes sense? They're pretending that this makes sense. I don't quite understand it, and I'm not quite sure how to fix it, other than just keep speaking up where I can.
And it seems like in an attempt to improve outcomes by suggesting that we dehumanize someone who's a different color than us, so we don't invest as much of our care in their outcome. But by suggesting that and categorizing everybody and breaking them into races, we basically are teaching people to dehumanize others. So it's using dehumanization to fight dehumanization.
You're right. It's doomed to fail, but in the failing, there will be so much loss. People will lose self-esteem. Patients will be hurt. Doctors will be hurt. You lose your integrity. It's a loss. There are no winners, I don't think, except for the people, making speeches for money and selling books. And that's, if you call that winning. But there are no winners. I don't see any winners in a situation like this. Nobody wins.
You both spoke to the sort of group think that you were seeing in the forum when the DEI issue came up among other surgeons who were communicating about this. And I think that's really surprising to a lot of people, to imagine that highly trained, highly capable, intelligent people can fall into such a lockstep groupthink, mob herd mentality. And how do you make sense of that?
Well, as Rick was saying earlier, there were several participants who were pushing back forcefully, consistently, repeatedly. So it wasn't universal. There were definitely a large percentage of participants who were saying, this is crazy, you're wrong. So that's encouraging. And I got feedback from a lot of the surgeons saying, thank you for speaking up. I agree with what you're saying. Thank you so much for speaking up. So thankfully, it's not universal, but as I say, a lot of them really have been drinking the Kool-Aid, and it really, you wonder if it's sort of a collective guilt about something that they're trying to fix, and this is the way to fix it, or if it's the goal of having more power, more control. I'm sure there are lots of psychological reasons, social reasons that contribute to people agreeing with things that they know are just crazy. And I don't really quite understand it. Educated people. I have people in my family. We grew up eating the same food, same parents. drink the same water that, that are all into this DEI thing and think I'm crazy. I mean, it's almost like a religion. It's not rational, and you can't, logic and information and data won't change their mind. It just won't. It's almost like they have to have a born again experience. It's very interesting.
Do you see it mostly as a generational issue, or are you seeing this across the age spectrum?
It doesn't seem generational. I mean, I see older and younger surgeons on the forum. There were younger ones, of course, that were all in, but some of the older ones as well. Maybe, I don't know, what was your sense, Rick? Did it seem to be more the older surgeons that were against it and the younger were for it?
Well, I don't know the proportions exactly, but I will tell you that the vast majority of people that have been supportive of my opinions and my concerns have been surgeons like myself who are more senior. Many of them are retired. And I think the younger surgeons are a lot more open to these particular ideas and are, as you say, some of them have just drunk the Kool-Aid of social justice and are, are into this thing in a very, very big way. I've come to the opinion that if I have to seek a surgeon out for myself, I don't care about race. I want somebody who's over 40 years of age and experience.
You're not kidding. You're not kidding. It's true.
I'm thinking into ageism now. That's my, or reverse ageism. That's my whole thing. I do. I don't want to. I feel like a third wheel here because I should just leave and let you all talk because I'm really enjoying this. But I have two quick things. So I'm going to leave it to you again because I want you to have as much time as you need. I guess a question and a request. The request is I really haven't heard you speak about the Zoom call. You and I did a Zoom call together with a member of the Board of Regents, the General Secretary, and the new Director of Diversity of the ACS. This was back at the very end of March of 2022. I'd love to hear your impressions of that particular Zoom call. And then my question is this: of the reasons that were given for me being banned for life. And by the way, I really disappointed Leslie because I thought you'd have a cake with a couple of candles or something to commemorate my second anniversary here. But I went into my third year of this as of April 17th. But the claim was that I was continuously disrespectful. And as someone who was on those forum threads and saw my comments and was on the Zoom call with me, which was basically the main interaction I had with the ACS leadership outside of the forums, did you conclude that I was continuously disrespectful in the way I presented the things that I was saying?
No, I think their problem was that you just wouldn't budge. You just wouldn't budge, and you were unrelenting. And they had no argument for what you were saying. I mean, that's basically it. You would not budge. And you're a good writer, as you know. You've been writing for columns for years and have a way with words. And I think you just got under their skin. I don't think it had anything, and that's the only language they could couch their concern in, is you were being disrespectful. Because basically, if you don't agree with someone, with these people, that's basically what it is. You're the bad guy. You're disrespectful, or you're the one that's the aggressor, or you're violent, or whatever names they want to call you. So it's just about calling names. I mean, you see that strategy in all throughout the society. If you're on the wrong side, they call you names. It doesn't have anything to do with reality. They just call you names. So, but the problem they had with you is that you wouldn't go away and you wouldn't shut up.
Would you
probably a badge of honor.
Go back to the timeline, and when did this Zoom call happen, and how was this set up? What was not exactly dates or anything, but what was the sequence of events that led to this?
I can probably speak to that a little bit because the comment thread ran from April through August of 2021. And then the comment thread kind of just slowly died out. People ceased to engage. And even I backed out. It was my comment thread that I began, but I backed out because I didn't think it was really going anywhere. And I was thinking about what comes next. And then, so that was in August when it kind of petered out. And it was around the end of the year, November or thereabouts, that I out of the blue, got a call from the General Secretary, Tyler Hughes of the ACS, who said that we would like to have a Zoom call. And I said, great, I'm delighted to do that. But the Zoom call didn't take place until March because they wanted to wait until they had brought on board their new hire. They opened up a Department of Diversity in the ACS, and they hired an executive director and a clinical director, another physician, and they wanted her to be on the Zoom call. So that Zoom call didn't take place until March. What happened was during this period, I had joined FAIR, the Foundation Against Intolerance and Racism, and I had made a number of contacts with different physicians. I was one of the founding members of FAIR in Medicine. And so I went to them and I said, I've been invited to a Zoom call with the leadership of the ACS. Can you all give me some thoughts and advice and whatever you think would be helpful to me to prepare for this? And one thing they said was, do not go into this Zoom call by yourself. Be sure you have someone that's on your side with you. And so I tried to get somebody from FAIR. FAIR has a lot of people that are actually known intellectuals and speakers and a lot more, articulate than I am. But the ACS would not allow anyone to come with me who was not a fellow of the ACS. And Celia, I'm not exaggerating. You were the absolutely first name that popped in my head when they said it has to be someone from the ACS because you were so supportive. I mean, you really backed me up a lot during that comment thread. So that's how I reached out to you and invited you. So that's how that Zoom call came to pass. And again, I would love to hear your impression of how you thought that call went, because that was banned just a few weeks after that call was completed.
Yeah, I thought it went well, but I tell you, I think they were primarily giving lip service. I mean, they went through all the reassurances that yes, our primary objectives are quality, and we don't agree that race should be a factor in deciding whether you're a surgeon or who your surgeon is. It should all be merit, should all be quality. I mean, that's what they were saying on that call, as I recall. They were reassuring us that they were not abandoning their desire to have quality and merit be the primary factors in surgical education and surgical care. That's what I took away from it. But I never got the feeling they were very sincere, but that's what they were saying. That's what they were saying. And it was non-confrontational. We were all agreeing on everything. We all agreed that surgery was great and there should be no race-based considerations. And their push for diversity was not going to compromise their standards for quality in any way. That was what they were saying on, as I recall.
And is that
the only thing you can say.
Is that what you're talking about when you say that they're not out front with their quotas?
Yes.
So you feel like there's some insincerity there, like they're kind of talking out of both sides of their mouth.
Well, they won't say how they're going to accomplish this goal other than hiring, a whole administrative staff. And having, when it first got on my radar was I kept getting emails from the college about online training for microaggressions. And I thought, why do I need training on microaggressions as a surgeon? I mean, surgical practice is by nature confrontational. I mean, you're often not necessarily in conflict, but challenged by the radiologists, the anesthesiologists, other providers. And that's how you collaborate on patient care, is people have different opinions about what the problem is, how to fix it, what antibiotic to use, when are we going to do surgery, what type of anesthesia are we going to use. The nurses have opinions. So there's, of necessity, this sort of innate confrontation in the practice of medicine, because you're collaborating with other providers. So I thought, if every time someone disagrees with me, that's a microaggression or they're racist, it's going to dilute that interaction, that interplay. Well, this is what I think. Well, no, I think we need to do this. Or the ER doctor will say, I think we need to do that. And I'll say, no, I think we need to do this. Those are all now microaggressions. And I thought, how did we get here? Why do I need a course on microaggressions? And why should I be offended every time someone disagrees with me? And if someone can't disagree with me because I'm a Black female, that's going to hurt the patients, because I'm not going to benefit from their perspective or information they have. The nurse has information that they're trying to get to me, but she's not going to share it because I'm Black, and she can't say something that might be a microaggression. The whole thing is demented. It's demented. You have to learn how to communicate as a surgeon. You have to learn how to be assertive. You have to learn how to listen. You have to figure out how to deal with your feelings getting hurt. I mean, even interactions with patients and families are often antagonistic and confrontational, because there's fear and confusion and lack of control. And, patients, none of us deal with that the same way. So teaching us to be offended every time someone doesn't agree with us didn't seem like something proper to be training surgeons. I mean, how are you going to take care of patients if you can't be assertive? And if you're going to be offended, if anesthesia says no, I'm to be offended instead of trying to advocate for what I want to. I thought that was the strangest thing. We're going to have a course on how to deal with microaggressions in surgery. That was the first thing on my radar. Mm-hmm. And then after that, then I started seeing this forum with Rick, as I described earlier. And I think they're still doing those courses on microaggressions. So, and then they're teaching residents now, I guess, that it's not, you can never be offended. How do you hold someone to a standard if you can't correct a surgeon in training? You can't ever offend them and tell them this is wrong, you need to do it this way. How do you learn? Mm-hmm. And what happens when you throw them out of residency and they're having to make the decisions and do the cases on their own? If all they've ever had is someone holding their hand, never correcting them, because now you, as a professor or an attending, you probably don't dare correct one of your Black female residents, or you'll be accused of being racist. So you let them pass through and just send them out into the world to take care of patients, never having been challenged, never having been held to a standard, never having their mistakes corrected. That's what I see as the end result of these microaggressions. Don't ever be, everything is an offense. Everything is an offense. Mm-hmm. As a female surgeon, it's just natural. People are going to call you miss instead of doctor, or assume you're a nurse instead of a doctor. Am I to get offended now every time? That it is insane. It is insane. It's not productive. It's destructive. So that was my first hint that something was wrong. And I don't think any of that has stopped, even despite their assertions that merit and standards will not be compromised. They're compromising something to get if that's what they want.
It sounds like, since you're not seeing hard quotas necessarily, you're seeing a lot of training that just introduces paranoid and neurotic, obsessive thoughts in people.
I think that's the risk. And I don't know when that'll show up at the bedside in a community hospital. It might be, time Rick and I retire and completely out of practice, it takes 5 years to finish your residency, you know, and then, the older surgeons will be phasing out and you'll have these neurotic new surgeons. So it'll take a few years before that shows up at the bedside. But I think that's where we're headed when, I'm out with the patient and I have one of these surgeons that's totally insecure, ill-equipped, poorly trained.
Are you seeing impacts in the quality of care due to this, or is it still sort of just like hints of this and the way that people are talking? Are you actually seeing people impacted by these policies negatively?
Not yet, because, like Rick was saying, all of us in our community, most of the surgeons and practitioners are older, what I see with younger physicians coming to practice now is primarily the philosophy of how much they're going to work, how much money they want to make. We're not taking call. We're going to stop working at 5 o'clock every day. We want this much vacation. That's more the trend I see impacting us right now. But I think if they continue with this push toward likely, decreasing standards, we're going to see issues with people not being able to get the patient off the table if they get into trouble, or figuring out who needs surgery or what surgery to do or how to do it, and poor outcomes. I think that's in the near future, but I haven't seen that exact problem right now.
And do you see any reasons for optimism in younger surgeons? Do you see people who are younger pushing back against this as well?
I haven't had the opportunity to interact so we don't have a training program, so I don't really see. I mean, we're part of UF. The trainees still do all their training primarily in Gainesville, not at the hospitals where I work. So, but I'm at the meeting here this weekend, and there's a whole group of young female surgeons that all seem very enthusiastic about being good surgeons, and wanting to work. So that is kind of optimistic, seeing the the love of surgery and the desire to make surgery a career. I think hopefully that'll push people to do their best and not try to be a victim surgeon, which it sounds like a nightmare.
Rick, you mentioned that it's a big anniversary for you. What's been happening as you approach that 2-year? Any progress for you?
In a word, no. I have been successful with getting a number of articles out that address not just my issue, because I think it goes beyond that. In the beginning, it was really me pushing back, and because I was so upset about what happened in the ACS, to me specifically, but also very discouraged by what was happening in the ACS in general. And it's kind of expanded out to what's happening with surgery. And like Celia, I'm not involved intimately with residency programs, but I do have a little exposure. Number one, I've got a daughter and a son-in-law who are physicians and came out of training within the past few years, and they went through excellent programs. They are both brilliant doctors. They're both smarter than I am. I'm in awe of the work that my son-in-law does as a pediatric orthopedic surgeon. So there is really, this is not an across-the-board problem. There's excellent surgery being done out there. But what's troubling, and I think where Celia is really being a little bit prescient, is that she's saying that this is going to be seen more. And I believe that's true because I've been in contact with some residents, specifically in plastic surgery. And just a quick example, when you do your surgical training, whether it's in general surgery or plastic surgery, you are to maintain a log of the operations that you are personally involved in, the operations you do, the operations that you assist on. And this log is used as part of the credentialing process. You have to turn this over to the American board of whatever specialty you're going to be applying for. And they review that to see if you've had a sufficient surgical experience to be qualified to take the examinations and become board certified. And what they've done now is they're actually allowing residents to list on their log operations that they have simply watched. They simply observed from behind the anesthesia screen, didn't even scrub in on.
You're
And
kidding.
because they observed that, yes, they are allowed, in fact, encouraged. This is coming directly from residents. Obviously, the one I spoke did not want to be named, but came to me because they were concerned about what they could do to obtain the necessary experience in their residency to feel qualified when they finished. And this is what they were telling me. And the other thing is that I have dealt with a couple of younger surgeons that have come out of residencies in the past 5 or 6 years. And I've gotten an occasional consult in the hospital to see something because they called the general surgeon in. I'll give you one simple example. A patient had a very large abscess on their scalp. And they called in the general surgeon to see the patient and take care of this. And this individual said, well, I don't feel comfortable taking care of this. I think you should call plastic surgery. Now, an abscess cyst on a scalp is something we would send the intern to do back when I was in training. It's not something that requires a subspecialist in plastic surgery. And yet and I don't know if the surgeon was simply truly felt uncomfortable treating this, or if they were just trying to sidestep the consult and send it off to somebody else. But I was just absolutely blown away that to me, it would have been an embarrassment for me to claim as a general surgeon that I can't handle a simple infected boil or cyst on someone's scalp. So I think there is an issue. And when I said I'm hesitant to go to a surgeon who's younger than 40, I'm being somewhat facetious, but there's a lot of seriousness there too, because the younger surgeons are the ones that have been inculcated in this whole idea that it's a lifestyle choice. They have to have this work-life, I guess the term now is a work-life balance. There has to be a work-life balance. And I knew coming into medicine, and Celia, I'm not going to speak for you, but I would suspect you would agree with me, that when you choose medicine as a profession, you realize that there's going to be times when you have to put medicine ahead of everything else in your life. That can be your kid's birthday, it can be your vacation plans, it could be your dinner at a nice restaurant that night. But you have committed to a profession where, when you are called to see a patient, that supersedes all other obligations that you have. And I think the younger generation has a lot of difficulty making that kind of a commitment. They want to work regular hours. They don't want to take any necessary emergency call. They want salaries that are above what I'm earning after 35 years.
Yeah.
So it's crazy. I don't know if you were aware, Celia, but did you know that over 80% of doctors today are now, I would say, owned? They're employed by corporations. They're not an independent practice anymore. And those things,
that, including me.
Yep, that goes to all sorts of things. There's a big push for productivity, to meet metrics, to get good Press-Ganey scores. And you need to have high patient satisfaction scores. If you don't have a good bedside manner, that could literally hurt you in terms of your salary, your bonuses, and your operating time. I mean, a surgeon lives or dies by having block time in an operating room, because when you have a lot of surgeons in a hospital, there's limited operating time, and the surgeons that are the most productive, do the most surgery, are the ones that get the most operating time. It's kind of a self-fulfilling situation. So yeah, I think there's a whole lot of things going on, and this whole thing of DEI just absolutely distracts from the real problems that we have. I mean, we have serious problems in surgery. The ACS has predicted that, I just got a number here, by 2034, it's not that far away, there's going to be a shortage of between 16 and 30,000 surgeons in this country. Now, how are we going to fulfill that need for surgery and maintain quality if we don't keep the standards up and we start putting anybody in that meets a certain, gender identity, or not gender, but identity box, if you will?
Right.
If we start making those a criteria for putting people in surgery, I fear for what's going to happen. We're going to see a radical decline in the quality of surgery in this country.
Mhm. But yeah, those things you mentioned are the exact reason that you can't force people to do surgery, especially women. I mean, that explains why traditionally you see more male than female surgeons, is because of those lifestyle things. You know that you're going to be having to compromise, having a family, more traditional female roles. That's why those doctors I know were trying to get me to talk their daughters out of going into surgery, because they know the commitment, they know the lifestyle. And that's why you can't enforce that from the outside. It has to be a personal decision. Yeah, this is the career I want. This is what I'm willing to give up to do this. You can't just cookie cutter, create female surgeons and stick them into the hospital. It has to be a personal decision because it's such a commitment. It's such a strain on a personal life and, on other aspects of being a woman. So it's not something that you can prescribe. It has to be a personal decision. So.
Well, I'm really grateful to both of you for this conversation. And Dr. Rick Bosshardt, I hope you continue to speak out and push this message so that people can hear about what's happening and understand the gravity of it. And Dr. Celia Nelson, I really appreciate you taking the time to share your own perspective and story and to illustrate how harmful these DEI practices and educational policies are to both the professionals and to the people that they're serving. So thank you very much. Do you have any resources you want to link people to or any recommendations for people who are interested in learning more?
I'm not really active on social media, so just stay informed. Stay informed. Mm-hmm. Keep your eyes and ears open.
And how about you, Rick?
Well, I have my as Celia said, I like to write, so
yes,
that's my primary outlet. I have a Substack. It's Richard T. Bosshardt, MD.substack.com. And I do try to post, I'm trying to post more frequently, and I'm trying to put in issues, posts that relate to these issues. I go broader than that. I don't want to be just a one pony type of an act here. But I do try to put things out there, and I am going to continue to put things out in the media. As far as other resources, I got to put a plug in. This is
your book.
FAIR has been very, very active in the area of DEI and pushing back, and most importantly in medicine. I don't think there's an organization that has been anywhere near as effective as Do No Harm. Do No Harm Medicine.org. And they are working. I mean, the organization has only been around for a couple of years, and if you look at what they've accomplished in terms of changing regulations and laws and pushing back against illiberal policies, some of these DEI claims that some students and residents have to fill out as part of their application. They have to buy into all this DEI stuff by saying how they're going to promote DEI. Mm-hmm. They've been pushing these back as being really restriction of free speech. And so Do No Harm Medicine.org is one that I can recommend very highly. They have all sorts of resources. And if you have anything to report, they're really looking for anybody that has an issue that they can look into. They'll be happy to do that. The last thing, I kind of walked away from the idea of pursuing any kind of a legal case against the ACS for banning me. But I have two complaints now being looked at by the Office of Civil Rights for the Department of Justice and the Department of Health and Human Services, because the ACS receives over $10 million every year or two in grants and contracts from the federal government. So they have to abide by Title VI of the Civil Rights Act of 1964, which says that you cannot be discriminating against people on the basis of race. And I truly believe that if I had been, Celia, I say this cautiously, but if I had been a Black female surgeon, I don't think the ACS would have banned me as quickly as they did.
Exactly. I agree. It's so outrageous.
Well, thank you. I will link to Do No Harm underneath of this, and I'll include any other links that you send me if you'd like any others added. And thank you both so much for sharing this time with me and for telling more detail about what's going on in surgery for people who don't know. Thank you.
Thank you. Nice
Celia,
meeting you.
I bow to the better writer and the better speaker. I could have listened to you for the entire time and not said a word. But thank you so much for being
Keep
willing.
fighting, Rick. Keep fighting.